Hi, welcome back to the Coda Podcast. I'm Ollie Flower.
And I'm Roger Harris.
Here's a podcast from our Coda 22 event, which I think we really feel was our best content yet. It was our best event yet, and it was so good to see everyone back together again after such a long hiatus, right?
So good. It was friggin' awesome to be back together. So much to be proud of. Agree. Maybe our best content ever. And how about having a Climate Active or Australian Government Climate Active certified carbon neutral event? That's a first.
It was one hell of an achievement there.
Massive achievement. And there'll be lots more on the website that you can track down about how we did that.
So please go to the website, check out the other podcasts and video content, the YouTube channel, and you can find us wherever you get your podcasts. And do share it with your network, tag us on socials, and spread the word, because this is the last Coda event and it's been one hell of a ride. So thank you for everybody who's been part of it.
Yeah, an absolute privilege to have been part of it. For more on the sort of winding up of Coda, check out on the website, and hope to see you all soon.
See ya.
Thank you, Greg. I've never had anyone make Excel look interesting, so I really appreciate that. That was wonderful.
And have you now seen someone who's made it interesting?
I'm now going to... We've run a little bit over time, but we still have time for questions, because I know you will have been feeding them all into the Twitter machine, and I'd like to throw over to Justin to take us through some questions.
Sure. I'll try and go in order of speakers so that you get some time to think and catch your breath. The first one is to Daniel, so if he's watching kind of offline or whatever, he can answer this somehow, or somebody can DM him. But the non-GP, the non-nurse, like a specialist surgeon, how can they help with his projects other than just giving money? That was a question.
But we'll make sure we put that to him, because that sounds like something that he could, a worthwhile thing to feedback. All
right. Jimmy, you have a 7-part question. There's a lot to it. It's different people. So do you think some of the absence of modifiable risk factors is because we're misdiagnosing or listening for atypical histories incorrectly in women, or is it really truthfully that they just don't have modifiable risk factors?
Yeah, thanks very much for the question out there. We often get this question, and I think both in men and women, the Smurfless group that we're advocating for here that really highlight the unmet need in heart attack prevention are partly to do with missed risk factors. And I think that's probably right, that in some parts of the world that may be disproportionate for women. But certainly underlying all of that, this is a real phenomenon, and it's not a new thing, and it's certainly now recognised right around the world. So when we actually get the cohorts and they actually do present, we can actually look and really clarify that those risk factors were actually not present. In all cohorts that we look at, we do find proportions of missed Smurfs, so to speak, but that's to be expected, and I think the disproportional effect on men and women is different in different countries that we see.
The second part is, are there any new or novel blood-based biomarkers coming online that are going to help with these identification systems?
Yeah, look, I think it's actually overwhelming if you actually look at the literature about the number of things in the blood that are associated with atherosclerosis or plaque. What the challenge is that we've actually really tried to bring together an expert group to achieve is, how do you convert that to deal with the unmet need? A lot of the previous biomarker discovery efforts have actually been targeted against events, so people that have had heart attacks in the community. But in fact, what we're trying to do is pick up the subclinical disease way before someone has a heart attack. And so that's where the actual imaging and CT coronary angiography of people that are actually having them can actually inform machine-based learning algorithms. So it's been really fun to get a bunch of molecular biologists, bioinformaticians, talking about dorky Excel, really trying to pull all this together. And I think one of the real challenges is identifying where this can make the biggest difference. Often we're looking at groups that are already identified as being intermediate risk individuals, but in fact the biggest unmet need is this low risk group that are currently not getting access to any treatment but are actually brewing ticking time bombs of plaque. And so if you have a test that can actually pick up even 60 or 70% of them, which if you look at a traditional ROC curve is actually not that crash hot, it's a game changer, particularly if you can then use it like we do in cancer to screen people into having a test that actually then identifies the disease that can be treated way before a heart attack. So I think the time is exciting over the next 5 years.
Yeah, that was one of the other questions, is what do you hope to see in the next 12 months? And you clearly just answered that, so good on you. Way to be psychic.
I'm not going to answer the rest of the 7-part question. You've got to give it to someone else.
Go to Maya. So Maya, in trauma, it's ABC, primary to tertiary survey, which is the historical model. Is it the right model for assessment of these low falls in older patients, or do you have a better, more appropriate paradigm?
It's a really great question. I think I've been thinking about this problem for a lot of years now, and I've looked at it from lots of different perspectives. I worked on a general medical ward for a long time. I work in the ED, and I've spent the last 6 months working in a hospital in the home. And the more perspectives I see these patients from, the less I understand about how to solve this problem, to be honest. And I think anyone who's got the answer probably just hasn't looked at it from enough perspectives yet. But I do think one of the common themes that comes out of all of this work in older patients is that it's about time. We need to slow things down from the traditional trauma paradigm of minutes to hours, and sometimes often days and weeks. And sometimes the diagnosis becomes obvious the more time we spend. And we know that as clinicians, right? The diagnostic tool of time is really, really useful. And I think part of the reason these patients are doing badly at the moment in our trauma systems is that time is one of the things we have the least of at the moment. So I do think we need to flip the paradigm of intervention being the goal to time spent with patients being the goal. And then the other biggest learning I've taken away is that the team member who's of most value in these patients is often the nurse or allied healthcare professional, which in the trauma world is a little bit of a flip too. In the trauma world, your acute care access is often generated right from that very first view of a paramedic, and they will often elevate you into some sort of trauma response that's very acute and urgent, or they will send you down a different care pathway. And these are very, very complex patients, often with multiple things going on at once. And so you need time with them, but you also need someone with them who can see what's happening over time. And so I've learnt a lot, for example, from the residential aged care population watching in-reach nurses or nurses who know the contexts very, very well, who review the patient in their context, looking at their function within their context and saying, well, you know, last week your function was very different to what your function is this week. There's something wrong here. And then spending more time trying to figure out what is wrong. And we often do a lot of our assessment at the moment in very time-compressed places where nurses don't have a lot of time, like emergency departments. So those are the only two things I've got so far, which is more time and more time with people like nurses who are at the bedside more often.
Thank you. And finally, Greg, this one's tangentially related to your topic. So chronically critically ill children who spend a significant amount of time in pediatric ICUs, do you have thoughts about how to make the transition when they continue to need ICU care and they have become adults?
Yeah, that's a really good question. I just want to reflect on Maya's answer that there's a quote I really like from a guy called Deming who said that for every complex problem there's an answer that's easy, simple and wrong. Also the same guy, just a font of great quotes, once said that in God we trust, all others must bring data. So. Transition, yeah, look, transition is a huge issue. And chronic critically ill patients, I was speaking to Gemma before about adult congenital heart disease. These are kids who did not survive until quite recently. And they're surviving for a whole lot of good reasons. We're getting better and better all the time in pediatric ICU. Our mortality is now 2.2%, 2.3%, and continues to drop remarkably. Over the decades, even though we don't have much further to go. There's technologies that mean these kids can survive outside the ICU. We have extraordinarily reliable home ventilators and ventricular assist devices. You know, there's kids in Texas, Justin, who've been supported on ventricular assist devices for, I think, 7 years while they go to school. And there's, of course, changing social attitudes to disability and expectations. And these technologies mean that a lot of these people can live good lives, and people are advocating for themselves. And so there's 3 really good reasons why there's more of these children, more of them are surviving, and they're all good things. But it does create difficulty in managing it. And I think, again, with this complex, to link back to the quote about complexity and easy, simple, and wrong, I think with complex systems, it's really important to just have a look at your local data and turn it into information and try and understand your own context better, because any kind of glib answer I can give from the stage is going to be tricky. I think links between the paediatric and adult services are, of course, really important. That's something we could still do so much better. I think bringing in the disability advocacy groups and the end users of our services into design of our services is going to make it so much better. And it's remarkable to me that so much of our design still doesn't involve them. I think the quote, nothing about us without us, really should apply to healthcare as much as anything else. They're my ideas about how we can make things better for transition. But it's coming, guys, in the adult services, and there's a big population of adult congenital heart disease and a lot of other stuff too.
Any compelling last question, Justin? Because
Nope.
Otherwise it shall be time for lunch, and I would love for you to join me in thanking this magnificent panel who I think you will agree have nailed their brief. Thank you so much.